Anyone? No issues. We'll start with hepatopulmonary and portopulmonary syndromes. Now, we receive a patient very frequently, right, of chronic liver disease, and they may end up with having breathlessness. They may end up in ICU with having breathlessness, or in ICU admitted with any other cause, and then you find patient is breathless. So always keep a very low threshold for having diagnosis of hepatopulmonary and portopulmonary syndromes. Now, what is hepatopulmonary syndrome? Remember the triad. For hepatopulmonary syndrome, the most important thing is it can occur in chronic liver disease or non-cirrhotic liver disease also. So you must have hepatic disease, portal hypertension. There must be intrapulmonary vascular dilatation. Can anyone just explain me what is intrapulmonary vascular dilatation? Anyone? See, this lecture is going to be interactive. It is not you will be just listening to me.
Due
Anyone?
to, due to
What does it
release of
mean by intrapulmonary vascular dilatation?
nitric oxide, sir.
So due to release of nitric oxide, there will be vascular or vasodilatation in where? In particular lungs, intrapulmonary, right? We know in chronic liver disease, everywhere it is a vasodilatation, but particularly in lung, it becomes vasodilated. Now, another third thing is A gradient, hypoxemia. Patient must have hypoxemia. That is a pulmonary arterial alveolar arterial gradient. It should be more than or equal to 15, right? Around 10 to 32%. I'm actually sorry for my voice. Throat is not good right today. So around 10 to 32% in cirrhosis candidates for liver transplant. So, so you can just imagine around 10 to 32% in cirrhosis candidate for liver transplant, it is prevalent. And the most important thing is without liver transplant, if you see the median survival, okay, it is hardly roughly around 10 months. And particularly why it is less than around 10 months, because if whenever you have a PO2 of less than 15, sorry, 50. Now, we already know about pathophysiology, what is happening. The most driving factor, or I would say the precipitating factor, that is the portal hypertension. That is the one which will doing everything. Portal hypertension, it will lead to gut bacteria translocation. There will be more and more increase in release of endothelin 1, and there will be more increase in nitric oxide production. It leads to intrapulmonary vascular dilatation, right? So how much it can lead to increase in that vessels? From 15 to 100 micrometer. Normal is around 8 to 15. And there will be a VQ mismatch plus diffusion perfusion impairment. What does it mean? So vessels are so much dilated, so the oxygen will be there, but it will not no bind to the overall RBCs, right? So they oxygen fails to reach to the central RBCs, and that will lead to refractory hypoxemia. The diffusion of the gases will not happen, right? Now, how will you diagnose? What are the clinical features? There will be platypnea and there will be orthodeoxia. Now, when we say about platypnea, what does it mean of platypnea? See, dyspnea is worsened by what?
Standing.
Upright posture. If your patient will tell you, sir, whenever I am lying down, I am feeling better. When you make them head up, or make them sit, or you make them stand, the patient will develop breathing difficulty. That is called platypnea. What is orthodeoxia? Your SpO2 will drop more than 5% or PO2 drop more than 4 on standing. That is orthodeoxia. There will be a progressive dyspnea cyanosis and clubbing. As we all are aware, signs of chronic liver disease, spider nevi, signs of portal hypertension, hypoxemia, all these there will be there. Now, how to diagnose? We already discussed about need to do ABG, calculate pulmonary alveolar arterial gradient. If gradient is more than or equal to 15 on room air, and again at 45-degree upright position of the patient, it is diagnostic. Now, another thing, contrast enhanced echo or bubble echo. What does it mean about contrast? Can anyone just tell me? Anyone have any idea about contrast enhanced echo or bubble echo?
Sir, we do contrast echo after giving IV agitated salines and look for the microbubbles formation. If
Okay,
that
look for the
microbubbles,
micro bubble formation where
if that
in echo.
microbubbles go to the right side of the heart,
Okay, so
and
rightly said. How you do? In one hand, you keep a saline agitated. I mean to say
Agitated saline.
10 cc agitated saline. Use a three-way cock. Okay, and by doing this agitated saline, you just push them. Now, these micro bubbles have a size of around 10 to 20, I would say, microns, right? While the capillaries are having around size of 8 microns. Now, because of this vasodilatation, these capillaries will allow that these bubbles to pass through these capillaries. And now, what does it mean about more than or equal to 3 cardiac cycle? Can anyone tell me? And if it below 3 cardiac cycles, then what does it mean?
sir,
Do you do anyone
Cardiac
have any
issue.
idea?
if it is after 1 to 3 cardiac cycle, it indicate maybe intracardiac shunt present.
What kind of intracardiac shunt? Absolutely right.
Right to left shunt.
Right to left shunt. So in a patient with ASD or patent this patent oval foramen, in such cases and also in ASD, you will have right to left shunt, and in such particular 2 3 conditions, you will have micro bubbles passing through less than 3 cardiac cycles, right? And if it is getting more than or equal to 3 cardiac cycles, it is what it suggests, intrapulmonary vasodilatation. What it suggests? Intrapulmonary vasodilatation. Now there is another diagnostic test that is called 99 technician level technician MLL lung scan. Now it is not easily available everywhere, telling you the truth. You need to see that shunt fraction. If it is more than 6%, it supports hepatopulmonary syndrome, and it also help you to quantify the severity. Now another diagnostic aid, that is pulmonary angiography, but it is reserved for large shunts. Now you also need to grade them according to severity based on your PO2 in your ABG and at what position. At what position? Excuse me.
Upright
Hello.
position. Upright position.
Upright position. So whenever you want to, grade them for the severity, you take ABG in which position? Upright position. You take ABG and then you calculate. If you see the PO2 is more than or equal to 80, it's a mild HPS. If you see it's around 60 to 79, it's suggest you of moderate. PaO2 of 50 to 59, it suggests you of severe. And if it is less than 50, it's very severe. Now, we around a month back, we discussed, I told you that I had a patient of this hepatopulmonary syndrome, if any one of you remember. It was a very severe case, and the PO2 was less than 50, right? So in such case, how do you manage these patients? Though lung may not be, sorry, liver may not be patient or relative with the sir, It doesn't look that patient will require urgent. There are no bleeding at present. There is no big or huge ascites, massive ascites right now, but they require urgent liver transplant. So for management of hepatopulmonary syndrome, liver transplant is the definitive cure treatment. It helps you to resolve hepatopulmonary syndrome in around 85%. And when you see the overall mortality is around, I would say 16% in hepatopulmonary syndrome in compared to portopulmonary. We will come in that later on. Okay. Now, what about oxygen therapy? Yes, it will help you. It's a palliative care. It will improve you, help you in improving symptoms, but it cannot reverse your intravascular vasodilatation, interpulmonary vasodilatation. Now, the question comes, sir, we talk about tips and all these things. Will tips be helpful in such condition? See, tips generally does not improve your hepatopulmonary syndrome. Why? Because here problem is not with the liver in particular portal pressure. Right now, because of this nitric oxide and everything, already pulmonary vasculature dilatation has been occurred. So now problem lies within the lung. So tips will not be helpful in this condition. Now coming to another point, that is portopulmonary hypertension. We discussed about hepatopulmonary syndrome, and now we are discussing about portopulmonary hypertension. Now, how you define it? It requires few parameters to define portopulmonary hypertension. Mean pulmonary arterial pressure more than or equal to 25. Pulmonary capillary wedge pressure less than or equal to 15. Why it requires? Because it rules out your left heart disease, your left ventricle. So it is not related to your left overall cardiac issue, right? And PVR more than 240 dynes. In which condition? Where you already, particularly in cirrhotic patients, it may occur in with or without cirrhosis patient. But again, the most triggering factor, that is the portal hypertension. What is the prevalence? Around 2 to 10% of portal hypertension patients may have portopulmonary hypertension. And 5-year survival, how much? Is around roughly 35 to 40% without liver transplant. If you see the prevalence in hepatopulmonary is 10 to 32%, which is more common than portopulmonary hypertension. So WHO is classified according to functional class of the diagnosis. Functional class 1 and 2 around 30%, functional class 3 around 50, and functional class 4 around 20%. They have overall survival, 5-year survival without liver transplant. Now, what causes all these things? Already know. Well, when we talk about liver cirrhosis, keep in mind portal hypertension is the main thing that is doing everything. That is, uh, uh, making the patient there, all the complications, all the things happening with the liver cirrhotic patients, all because of portal hypertension, nothing else. So that's why we focus and we aim and tell you that whenever you have a patient of liver cirrhosis, try to focus on managing portal hypertension first, right? So it will lead to portosystemic shunting, that will lead to vasoactive mediator bypass and hepatic clearance, more and more vasoconstrictor, reduce in vasodilators, shear stress and inflammation. Moreover, important thing is here in portopulmonary hypertension, that is RV pressure overload. That is RV pressure overload, RV dilatation, tricuspid regurgitation, and RV failure. So whenever you receive a patient of RV dilatation, tricuspid regurgitation, and RV failure, think about portopulmonary hypertension in such patient. Now, what are the key concept you need to keep in your mind while deciding or discussing or thinking about portopulmonary hypertension? Unlike hepatopulmonary syndrome, where it is a hepatopulmonary intrapulmonary vasodilatation, portopulmonary hypertension is vasoconstrictive. Hepatopulmonary is anyone?
Dilatation.
Yes. Hepatopulmonary vasodilatory, portopulmonary vasoconstrictive. So, yes, these two things you need to remember because both of them, the pathophysiology is different in both of them. So, in PPH, portopulmonary hypertension, portal hypertension triggers, right? So, in PPH also, if you, in particularly hepatopulmonary syndrome, we discussed that tips will not be helpful. But in portopulmonary hypertension, tips can worsen your PPH. How? We already know what is happening in PPH. RV pressure overload, and it will again increase your RV pressure. How? You know, if you put the tips, I will just try to show you if I can. It will be very just to make you know. It's a tips transjugular intrahepatic portosystemic shunt. Okay, what it will do? Can anyone just help me? Tell me what it will do? Tips transjugular intrahepatic portosystemic shunt. It will intrahepatic portal and system. So from liver to system, okay. So whatever the blood is there, it will reduce the pressure in the portal system, and directly it will go to the RARV into the system. So it will again increase the RARV pressure load. So RV pressure will be increased. That is why these tips will worsen your PPH. Remember, in PPH, do not think about tips. Remember, in PPH, portopulmonary hypertension, it worsens your PPH. Tips worsens PPH in this portopulmonary hypertension and hepatopulmonary syndrome. You may or you may not do, but it is not going to help you. Now, how will you define PPH? The most common exertional dyspnea. What is the differentiating feature from this one? Hepatopulmonary? Anyone?
Platypnea.
Sorry? Yes, you were right, please.
Platypnea.
Platypnea. Yes. Here it is exertional dyspnea. In portopulmonary, it was platypnea. Right? So just remember, most common thing is exertional dyspnea around 80%. Patient may have fatigue, chest pain, pre-syncope, syncope because of high RV pressure load. IVC will be congested. You will be having edema. Though you may think initially that this edema because of hypoalbuminemia, but again keep a very close eye on 2D echo on your RRV size. Patient may have hemoptysis, that is a very rare, and you may have RV failure signs, which we have just discussed. You can have elevated JVP, peripheral edema, and ascites. Always look for the loud P2, RV heave, tricuspid regurgitation murmur, and whenever you do echo, you will be able to find out. So, how will you diagnose? You do 2D echo. You see the pressure, RV systolic pressure, more than 50. Keep a very high suspicion, for portal pulmonary hypertension. How do you confirm? We already discussed. What are the diagnostic criteria? So for this criteria, what you need to insert PA catheter, right? By doing this, you will be able to find out the overall perfect numbers, exact numbers, what are there about the pressures, and then you can diagnose. Now, how do you assess? You can always give a 6-minute walk test. You can do BNP, anti-pro-BNP. You can use HRCT, pulmonary angio. You can use VQ scan, but most of them now 6-minute walk test. Do you think this 6-minute walk test would be helpful in ICU patients? Any of you?
No, sir.
Hello. Yes,
No, sir. Patient is already sick in ICUs.
patient is
Already sick and having multiple comorbidities, sir.
yes. Then it will not be helpful, right? So we can send BNP, anti-pro BNP, right? So by doing this, we will be able to assess our patients. Risk: mild pulmonary arterial hypertension or P pressures around 25 to 35. Moderate, we know 35 to 45, and severe is more than 45. While we think about diagnosing portopulmonary hypertension, where we have a severe pulmonary hypertension or pulmonary arterial pressure, so it is more than 45. Generally, when we do echo in such patients of chronic liver cirrhosis, we do have more than pressures more than 50. How do you manage? See, we all discussed what is the most curative thing for all these patients, liver transplantation. Now, again, it depends on the PA pressures. In which exact numbers of PA pressure you can go for liver transplant, and in which it is going to worsen the condition. The medical therapy, the pressure lowering therapy, you can use sildenafil, you can use ambrisentan, you can use IV epoprostenol. Now, for liver transplant decision, if your mean pulmonary arterial pressure less than 35, again, telling you, first, manage pharmacologically, lower the pressure. Second, try to keep it around 35-40. And by doing this, if patients are fitting into this zone, then and then only liver transplantation will be safe in such patients. Because in portopulmonary hypertension, the post-op mortality is very high, around 35% post-op mortality is there in PPH, portopulmonary hypertension patients, right? So if your pressures are 35 to 44, consider after pH overall pharmacological treatment. And if your pressures are more than 45, as I told you, liver transplantation is contraindicated in such patients. Now, what is the supportive or things that you need to avoid? As we discussed, what you need to avoid in these patients? Can anyone tell me?
Tips.
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 In PPH patients, avoid tips. It will worsen the condition because it will increase the RV pressure overload, right? You can, whenever you are using diuretics, how will you reduce the pressure? You need to use diuretics, but patient is of liver cirrhosis, use diuretics with very caution, because what it will lead to? Chronic liver cirrhosis, what it may lead to if you over diuresis the patient?
Dehydration and HE can present.
Dehydration, AKI, and ultimately you'll end up with more and more complications, right? And then you'll end up thinking about what?
Hepato-renal
Hepato-renal syndrome. So ultimately you'll end up thinking about hepatorenal, but actually it is a dehydration or hypovolemia that is causing. So whenever you are using diuretics for RV failure, use it with very cautions. Anticoagulation, case by case, it varies. You need to think about it because there is a risk of what variceal bleed is there, because many of the patient, most of the patient will have varices if unless it has not been variceal band ligation done on those patients. Now, hepatopulmonary and portopulmonary hypertension, what are the key differentiating features? We already discussed about pathophysiology. The most prominent feature that is pulmonary intrapulmonary vascular dilatation in HPS, while vasopulmonary vascular constriction in PPH. PPH, that means not postpartum hemorrhage. Here it is portopulmonary hypertension. Now, what is the hemodynamic changes or overall indices? Low hypoxemia, low PaO2. Okay, there will be hyperdynamic circulation, while in portopulmonary it will be hypodynamic circulation, because you see pulmonary capillary wedge pressure will be normal in portopulmonary hypertension. The hallmark symptom, as we discussed, platypnea and orthodeoxia. It is the hallmark symptom of hepatopulmonary, right? And for portopulmonary, exertional dyspnea. So whenever you are, if you don't have some hemodynamic indices, or you are not able to do contrast echo, just see the features. If patients are getting better, because overall, if it is related with RV failure, what will happen with lying down position?
Worsen.
It will worsen, right? While patient of hepatopulmonary, they will say, I am feeling better, right? So these are some differentiating features. Just keep in your mind while managing this liver cirrhotic patients. Again, contrast echo, positive bubbles in LA more than 3 cycles. There is a diagnostic hallmark. While in PPH, if you do echo, you can find RV dilatation. There will be more RV systolic pressure, and there will be not positive for shunt. ABG, hypoxemia, hypocapnia, and the most important, A gradient is more than equal to 15. And here, there will be normoxia or mild hypoxia. What is the role of tips?
Not recommended in HPS, sir, but it will worsen in PPH.
So always it is contraindicated in PPH while it is not recommended in HPS. Both are different things. Not recommended and contraindicated, right? So just keep in your mind that it is contraindicated because it will worsen the PPH. What will be if you give the oxygen to the patient of both the condition, what will happen to them? Now, if you give 100% oxygen, partial improvement will be seen in hepatopulmonary syndrome, while minimal improvement you can see in portopulmonary hypertension. What about the liver transplant? Curative in 85%. Okay, and absolute contraindicated liver transplant. When we talk about RVSP pulmonary pressure in PPH, here in hepatopulmonary syndrome, that is PaO2. If it is less than 50, absolute contraindication for liver transplant. While in PPH, if you see PA pressures more than 50 or 70, it is contraindicated. It is not going to helpful because ultimately patient will die. Treatment, liver transplant, oxygen therapy for hepatopulmonary, and for portopulmonary, first with pharmacological therapy, reduce the PA pressures, and then liver transplant after control of the pulmonary arterial pressures. So for take-home message for both these things, hepatopulmonary and portopulmonary, just hypoxemia, intrapulmonary vasodilatation, portal hypertension. If you see this triad, screen with bubble echo, do ABG, check the A gradient, and if it is more than or equal to 15, liver transplant is the curative. 85% in 85% cases, it will help liver transplant. Tips does not help in HPS. For PPH, high PA pressures, do echo, right side of heart, right heart echo. Treat pharmacologically, go for liver transplant, contraindicated in PA pressure more than 50. And again, tips worsens the PPH. Now distinguish, both of them share portal hypertension. The fundamentally differs. As we discussed, in hepatopulmonary, vasodilated lungs, that is hypoxic. In portopulmonary hypertension, vasoconstricted lungs, that is pressure overloaded. And platypnea will occur in HPS and exertional dyspnea in PPH. So you need to screen all of your patients of liver cirrhosis while you see patients are having breathing difficulty. It may be due to what? PPH, portopulmonary. It may be due to hepatopulmonary, or what other things can be? Anyone? These two things we have discussed. Any other for the condition that can be giving breathing difficulty in liver cirrhotic patients in ICU?
HE can lead to respiratory center depression, also leading to
Can you
shortness of breath.
please speak loudly?
Sir, HE can lead to respiratory center depression, can lead to shortness of breath.
What lead to?
HE, sir. HE can lead to respiratory
Hepatic
center
encephalopathy.
depression.
Yes. Okay. Hepatic encephalopathy. What else?
And
Pleural effusion.
massive ascites, massive
Massive
ascites.
ascites, pleural effusion. Very good. What else?
Hepatic
Is
hydrothorax.
it PTE, sir?
Sorry.
Hepat
PTE?
Pulmonary
Can you please speak
thromboembolism.
loudly?
Thromboembolism?
Yes. You can have patient may have pulmonary embolism. You may have thromboembolism. Yes, absolutely right. Anything else?
Hepatic
Stents.
hydrothorax.
Yes.
Tense ascites can also cause a bit of
Yes,
dyspnea.
tense ascites will be good. So overall, all of you are right. Besides this PPH and HPS, hepatopulmonary and portopulmonary, hepatic hydrothorax, okay, that will massive ascites will push the diaphragm up, will be leading to breathing difficulty, bilateral pleural effusion because of hypoalbuminemia, and the important thing, patient may have what? Volume overload because of albumins are being given. Now patient may have INR derange, you may be giving FFP something. So patient may have fluid overload. That may
Fluid
also lead to,
overload.
yes, that may also lead to breathlessness. So whenever you are dealing with a patient of liver cirrhosis with breathing difficulty, you need to keep in mind about all these things. Just does not think about PPS, HPS. You think about all these things, then also keep in mind about all these two, PPS, portopulmonary and hepatopulmonary. Right? Concept clear till now?
Yes, sir.
Yes, sir.
Okay, moving forward. So what is acute on chronic liver failure?
Sir,
Right?
I have one question, sir.
Yes.
Sir, actually, the basic pathology is of the chronic liver disease.
Yes.
Pulmonary vasodilatation is explained by the nitric oxide.
Yes.
One way we are saying that it can lead to pulmonary vasodilatation because of NO. But the same pathology is also causing pulmonary vasoconstriction.
Yes.
How that is explained, sir? Because nitric oxide will be released that part also, no, sir?
Both the way. Yes. Yes. Just. Let me explain you.
Quite contrasting, like both the things
Yes.
are occurring with same
Now.
pathology.
Yes. Yes. Now, see, I'll just tell you, in hepatopulmonary, because of endothelin and increase in nitric oxide production, there will be excess nitric oxide where?
In pulmonary circulation.
Pulmonary circulation, right? This nitric oxide, if you see, portal hypertension will lead to gut bacterial translocation, right? This will lead to endotoxin release, this macrophage activation in pulmonary vasculature. Because of all these things, there will be excess nitric oxide, particularly circulating in where? Intrapulmonary vascular. That will lead to intrapulmonary vascular dilatation. While in this portopulmonary, because of portal hypertension, because of portal systemic shunting, right? If you remember, initial, I'll just try to give you what will happen because of portal hypertension. If you, I don't know, have you attended my past lecture? I'll just show you. Why it happens, I'll just show you. Right. So, right. Now, are you able to see the slide?
Yes, sir.
Right. Now, what happened? There will be a clinically significant portal hypertension, right? I'll just make it enlarge. Now, this will lead to varices. Okay, there will be increase in portal venous inflow. There will be increased cardiac output. There will be splanchnic vasodilatation. Then activation of what? It leads to activation of what? RAS system. What?
RAS system.
Renin, angiotensin, aldosterone system. This will make more and more vasoconstriction. Okay. Because of effective hypovolemia, because of all these things, there will be more and more RAS activated. This will again, I will show you. Just a moment. So more RAS activation will lead to more vasoconstriction. Yes. So why development of ascites? Okay, because of this fluid leak into the peritoneal cavity, there will be systemic inflammation. There will be splanchnic systemic. We already discussed in past lectures vasodilatation. It will, because of vasodilatation, there will be reduced mean arterial pressure, and then there will be activation of what, this neurohumoral system, that is called RAS. This will lead to sodium retention. This will lead to more and more further increase in inflammation, increase in vasodilatation, increase in reduction in BP, and that will more and more give vasoconstriction of the, because of the RAS activation. So all these other parameters you can see downward is all be renal vasoconstriction. All vasoconstriction is because of RAS activation. I hope it had cleared your doubt.
Sir, we didn't have this class, sir. Can we
Sorry?
have it later? We never had this lecture, sir.
No, you had, dear, but I don't know. Did you attend or not?
No, I've attended all classes, sir.
No, but this class has been taken. I can just tell you later on in which group you are. You are in EFIC or triple CM.
FX, sir. FX, sir.
It has been taken by me, only taken. We'll let you know. But let me see. We can find if we have a recording. I think the
Okay.
recording will also be there. We can share
Okay,
with
sir.
you. There is
Yeah,
no.
yeah. Thank you so much, sir.
Okay. So moving forward. So dear, did it clear your doubt?
Yes, sir. Thank you, sir.
Yes, pulmonary, if you see here, pathophysiology, both of them, pulmonary vascular constriction, here it is dilatation, right? So acute on chronic liver failure, why it happens? We see many patients, having a CLD, that is compensated stage, right? And then they have some or other kind of a precipitating factor, and then they'll end up with having acute on chronic liver failure. Now, the most important thing is, because of alteration in gut barrier or the gut liver changes and immune dysfunction, these are the main two things. Because of the translocation of the bacteria and bacterial products, more bacteremia, more pro-inflammatory cytokines release, and because of PAMPs and DAMPs, ultimately, because of SIRS, it will lead to organ failure. And that will be acute and chronic liver failure. Now, what are the key pathophysiological derangement? Acute hepatic insult. Now, a patient of chronic liver disease who already was in compensated stage, everything was fine on medication. Now he has around 1 or 2 liters of alcohol intoxication. He is having hepatotropic viral or any drugs he is taking. There will be a flare of autoimmune hepatitis, maybe a sepsis from any other source, or this patient may develop portal vein thrombosis. So this can lead to acute hepatic insult and landing up the patient in the ACLF. Cell death and inflammation, already discussed, and immune paresis. So all these things will lead to derangement for development of ACLF. Now there are so many organizations came up with different definition. So how can one define about acute on chronic liver failure? So Britishers came with new guidelines and definition. European came up. So all of them came up with some or other kind of a definition or the guideline of that acute and chronic liver failure. But ultimately none of them will be properly justifying the development of ACLF and the definition of ACLF, because all of them had some kind of lacuna in them and they were, having something left. So American College of Gastroenterology had defined Bajaj and colleague. They defined ACG, American College of Gastroenterology, 2021. They have given the guideline. ACLF is a potentially, remember, reversible condition in patients with chronic liver disease with or without cirrhosis, that is associated with the potential for multiple organ failures and mortality within 3 months in the absence of treatment of the underlying liver disease, liver support or liver transplant. So in patient of chronic liver disease with or without cirrhosis, so it can be acute autoimmune hepatitis, it could be any other condition, not particularly cirrhosis, with or without cirrhosis, but chronic liver disease associated with what? With the potential for multi-organ failure, right? And mortality within 3 months in the absence of treatment of underlying liver disease, liver support or liver transplantation. So they came up with grading. You can find it online very easily. You can find it. ACLF, acute and chronic liver failure grading. They have came up with 1, 2, and 3 grades. So all of them, they define, if you see the organ system, liver, kidney, brain, coagulation, circulation, respiration. So it's about multi-organ failure, right? Let us discuss about individual organ failures. In brain, what this patient can have? Hepatic encephalopathy, race, grade 1, 2, 3, 4. In respiratory system, they can have ARDS, right? In circulation, they can have hypotension, shock, septic shock, and they require vasopressor. Bilirubin would be more than 12. Suppose patient of CLD have around 2 liters of alcohol. What will happen? They will be having a more hyperbilirubinemia. There will be derangement in INR. What will happen to the kidney? Again, it defines creatinine of 1.5 to 1.9, more than or equal to 2, and patient requiring renal replacement therapy. For adrenal glands, is the development of adrenal insufficiency, if patient have developed cirrhotic cardiomyopathy. So all these things, all the organ failure, according to their status, it defines on ACLF 1A, 1B, 2, 3A or 3B. So multi-organ failure, you need to define according to the status of the organ of that patient. Now, when we discuss about brain failure, right, or acute encephalopathy, see, in CLD patient, chronic liver disease patient, mostly it is hepatic, but it does not mean every time it is hepatic always. Why? Can anyone tell me why? Hello?
It can be alcohol related. It can be
Yes.
alcohol withdrawal also. So.
Some brain infections.
Yes. What else?
Electrolyte abnormalities.
Electrolyte abnormality. Yes.
Benzodiazepines.
Increased ammonia.
Benzodiazepines for sleep.
Yes.
Cerebral edema.
Yes. But why cerebral edema? So overall, I think you are getting my point that always it is not most common it is hepatic encephalopathy, right? But 110% always it is not be there. There might be some kind of drug overdose that patient might have taken. Maybe patient is having some psychiatric disorder and taken some, or patient is under influence of some antipsychotic drugs, right? Patient may be having some neurological disorder. Patient of CLD may have sudden AFib and now is having stroke, right? Patient of CLD may be having alcohol withdrawal. They may be having delirium. They may be having dementia, may be having infection like meningitis, right? So always remember, evaluate for alternatives always, and try to identify the precipitating factors. And if they are reversible, we need to reverse. Like if infections are there, you need to treat with antibiotics. GI bleeding, need to treat that. Electrolyte disorder, if you see diuretic overdose, okay. Now what you need to do, if you diagnose hepatic NKF, we all know how to treat lactulose, rifaximin, okay, lactulose enema. The first thing with brain failure, and when the patient is having a very low GCS, stabilize airway, triage appropriately, do all your lab works, give fluids, RT insertion, right? So how do you, not only hepatic encephalopathy would be the precipitating factor for acute and chronic liver failure, there are other factors also. So keep in mind, just does not label, mostly it is hepatic encephalopathy, but not, one size does not fit all. This way, every time it is not be hepatic encephalopathy, maybe something else. So just keep in your mind and remember this thing.
Sir, how common is ICH due to deranged INR in
Very common, very common, very common. So always, as I told you, always, I regularly use one thing. How many hands are you able to see right now? One?
one end?
Yes. How many hands are there?
Two.
Two. So always keep in mind, whatever you are thinking, you may think that it is hepatic encephalopathy, only looks like, but always try to overdiagnose. 90% of time you will have hepatic encephalopathy, but 10% cases you may have something else. Rightly said by you, it could be intracranial bleed, right? Yes, it could be stroke also because of AFib. Patients are on diuretic, right? Suppose patient have the AFib and because of that cardioembolic stroke patient had, then if you label it with only hepatic encephalopathy, and every time, all the patient, sometimes you feel patient is resisting, patient is not properly answering or not moving their hand, it will come on next day or after 2 days, we will reevaluate again about neuro part. So remember,
So,
it's
so,
not
sir,
always NCAF.
if we are suspecting NCAF, and for how much duration should we wait that HE should be recovered by this time, so that we should move for CT scan head or something? For how much
No,
time? After how much
it
time?
depends. As we discussed in past lecture, it depends on the grading of the hepatic encephalopathy, right? Sometimes overt hepatic encephalopathy you can also see. Now, if patients are having hypokalemia, right? No matter how much you treat about for your hepatic encephalopathy, your patient will end up with more and more. So overall, the grading will increase because of the hypokalemia. So always keep in mind, while patients you are receiving with hepatic encephalopathy, treat the potassium first. And again, nobody can say this is the duration in which time period you will have improvement or more worsening of the patient condition. So keep in mind about delirium. Pain can lead to delirium. Pain could lead to agitation, alcohol withdrawal, alcohol intoxication, sepsis. Whenever you receive a patient with altered sensorium with CLD, you can need to think about all these things, right? As already discussed, medication for sleep and pain. Now, whenever you receive a patient of acute and chronic liver failure in ICU, right? How will you manage? First, evaluate the etiology of shock. I am talking about with shock. ACLF ICU patient with shock. Evaluate the etiology. Is it hypovolemic, septic, cardiogenic, or distributive? Here, what does it mean, or what I'm telling you about distributive? Can anyone tell me?
Because of vasodilatation system, overall vasodilatation, so there will be fluid leakage. There will,
Yes.
so that will be considered.
Okay. And what about obstructive?
So like pneumothorax, pulmonary embolism.
Yes.
And cardiac
Very good.
tamponade.
Yes, very good.
Yes.
Very good. You guys are rocking today. Great. Right? So what you need to do, you do focus, do echo, if able transthoracic, right? If you have access, you can do arterial placement, CVP placement. do echo, see LVRV, measure CVP. Then, if EF is low, you know, or RV dilatation, you can use inotrope or vasopressor. If you see a low cardiac index or normal cardiac index, LV and RV functions are good, and see that hypovolemia is present or not. If hypovolemia is present, you do passive leg raise, give fluid bolus. If it is fluid responsive, give more fluid. If not responsive, continue with vasopressors. If refractory shock, we all know how to treat steroids, adding one more vasopressor. Now, what about kidney failure? You need to see about kidney failure phenotype, right? Is it structural? Is it HRS AKI or is it pre-renal azotemia, right? Treat according to AKI etiology. Remember, if you think about HRS AKI pre-renal, withdrawal of diuretics, nephrotoxic drugs, treat infection when you see blood transfusion for GI bleed if HB is less than 7, right? Now, daily closely monitor and observe the blood reports. Again, as we already had about cirrhotic patient, how to deal with HRS AKI, treat with vasoconstrictor. Which vasoconstrictor? Anyone? Vasoconstrictor plus albumin. Which vasoconstrictor will you use?
Early present.
Terlipressin.
Yes,
Terlipressin.
terlipressin. Yes. Yes. Then, if you see gradual decrease in your serum create less than 0.3 of baseline, then you can see, yes, patient is improving from the HRS AKI. So whenever you have patient with admitting with ACSF acute on chronic, always look for infection workup, send blood culture, urine culture, do X-ray, CTs. If at all, do the USG abdomen. If you see any ascitic fluid, go for paracentesis and see for SBP, right? Give immediate antibiotic according to your hospital. If patient had any history of hospitalization past, okay. In ER only, try to follow the sepsis bundles, the sepsis 2026 guidelines, right? Give antibiotic according to the overall suspected organisms, right? If patient is having diagnosed, if you diagnose with hepatic NKF grade 3, 4, go for airway protection. If you see hypoxemia, PaO2 less than 80. Now, very interesting thing. If you have a patient in acute liver failure, if you have, breathing difficulty, what does it mean? I'm not talking about acute on chronic. I'm talking about acute.
ARDS.
Yes, ARDS would be the most, factor or most common cause for breathlessness in acute liver failure. In acute on chronic, as we discussed, could be HPS, PPH, anything. So, look for hypovolemia, look for hemoglobin, look for mean arterial pressure, try to keep it more than 65, and sepsis evolution we already discussed. And always keep in mind about general care, this hug me fast, beat hug me fast, do investigation, treat your infection, and keep the general measures. How will you treat? Airway, multidisciplinary team approach, nutrition, treat the precipitating factor for each patient, right? Specific treatment about GCSF stem cell therapy, data are not convincing. What about liver assist devices, Mars and ELAD? Data are not convincing. Liver transplant, two kind, acute and chronic, they may end up in liver transplant, requirement of liver transplant also. Deceased or living donor, the greater evidence for deceased donor rather than living donor. So whenever you have donor, deceased donor is available, it's very good evidence for good outcome for liver transplant in acute and chronic liver failure. So take home message, decompensated cirrhosis, how to prevent? The most important thing which is causing every complication,
Portal hypertension.
portal hypertension, right? That in today's condition, it is a Donald Trump, right? So portal hypertension, treat with non-selective beta blockers. with compensated cirrhosis and clinically significant portal hypertension. What are the two main decompensating events?
Hypovolemia.
No,
GI
decompensating
bleed.
ascites and bleed,
GI bleed.
variceal bleed, right? When will you go for preemptive tips? Whenever you have a patient with acute variceal bleed, think of preemptive tips. I don't know how many of you have attended last lecture, but who had attended, they know what is preemptive tips, and that is to be done in a patient with child C group or of the score of 10 to 13 points. Which non-selective beta blocker will you use?
Propranolol or carvedilol.
Sorry?
Propranolol.
Propranolol.
Propranolol,
So that
nodenolol.
means whoever is answering has not attended my last lecture.
Carvedilol, sir.
Sorry?
Carvedilol,
Why carvedilol?
it blocks
Additional alpha-1
Yes,
action.
it has got additional alpha-1 blockade. That is why it directly work at which level?
sinusoidal,
Level,
sinusoidal.
sinusoidal level. Right, absolutely right. So that's why carvedilol is the drug of choice for prevention of portal hypertension. Okay. Now, refractory
Sir,
ascites.
can I ask, sir, for carvedilol, the starting dose, what is the starting dose we need to
At which dose?
give to the
See,
patient? Like,
no, you need to titrate it according to patient's clinical condition. Why? If you give more dose, ultimately you'll end up with what? What it will give you?
hypotension.
Yes, and we do not want that.
Hypotension.
Hypotension ultimately will lead to
अन्वी तेज है.
renal hypoperfusion. Yes, so that's why this carvedilol must be used if you remember that heart comes up and goes down. In which condition? Until that stage, at the stage where there is a very less decompensation. Once patient decompensates in a severe stage, please avoid, because ultimately it will reduce the myocardial activity, contractility. So again, more and more hypotension, more and more renal hypoperfusion, and again development of this HRS-AKI in CLD patient. That's why if you use, titrate the dose according to patient's condition. Start with low and then go high. Right?
Yes, sir.
In difficult to treat ascites, albumin tips. Right? Excessive albumin, why you need to be very careful? Though data, the trials and the study shows 1 to 1.5 gram per kg, max up to 100 gram in SBP also. Not a single Indian patient will tolerate this dose. Why?
Pulmonary overload.
Pulmonary edema can occur.
Why pulmonary edema? Because most of the Indian patients, 90% of Indian patients who are having all these things, they will have diastolic dysfunction of the heart. Diastolic heart dysfunction. And because of diastolic dysfunction, they will have, or they will lead to sudden pulmonary edema because of fluid overload and this albumin and everything. So, though it is indicated to give 80 gram, 90 gram, but hardly you can just end up, giving 2 albumins of 100 ml, right? You cannot give full albumin, and I'm sure there will be very less people. They will tell you that yes, sir, I am using 100 gram or 90 gram of albumin in my patient. There are 3 or 4 or 5 albumin in a day. No, not a gastrophysicians are using 4 or 5 albumin in a day. They are also not using, because they know in Indian people they are having diastolic dysfunction.
I think, Dr. Vivek, the cost becomes prohibitory.
Yeah,
At
cost
that
is
kind of
also a
aluminium.
problem, but again, yes, it's a very good thing. The cost is also there, but again, when it's around 8,000, around 32,000, but while they are spending, relatives are spending lakhs and lakhs per day, 30,000 doesn't come. But sometimes, yes, Dr. Suman works in a liver transplant unit. He knows the main, factor which are there, that is the cost.
Where we get stuck, we would love to
Yes,
give 3
that's
to
why
4,
he
but
knows the factor. Absolutely
yeah,
right, Dr. Suman.
yeah. Please carry
So
on.
preventing the AKI and progression to HR is the most important in patients with cirrhosis. Remember, preventing the AKI and progression to HRS, that is more important. Okay. In ACLF, infection are one of the major reason for ACLF. Okay. Keep a high index of suspicion. Okay. For antibiotics, for acute kidney injury, everything. Not all high creatinine is HRS AKI, and not all confusion is hepatic encephalopathy. Take it with a pinch of salt. Not all high creatinine is HRS AKI, and not all confusion is hepatic encaph. Use albumin selectively. Avoid unnecessary PPI. Why? Why unnecessary PPI to be avoided? Anyone? Hello?
To decrease the bacterial overgrowth.
Yes. You people are knowing everything, yeah? Come on. Because of bacterial overgrowth, ultimately what it will happen? Bacterial translocation, and again SBP, and so and so and so. It will end up with so many complications. Okay.
Yes, sir.
Again, the final wording, better biomarkers to predict ACLF are needed, and still more and more workup are required for acute and chronic liver failure. Let me end up with a very good case, and all of you will, it's a very interactive. Please try to answer. Okay. 59 male, chronic alcoholic, uncontrolled diabetic, morbidly obese, on irregular treatment, lost follow-up, brought by the relatives with altered sensorium, abdominal enlargement since last 2 to 3 days. History of appendicectomy 1 month back. Pulse 90, BP 100/70, shifting dullness present. Bilirubin is 2, create is 1.3, albumin is 3.1, INR is 1.4, WBC 7,000, and platelet 1,05,000. What will you do? What is the diagnosis? What is happening with the patient, and what will you do? Anyone?
Do the
Seems
sugar.
to be CLD with ascites.
Just do the
CLD with
sugar.
ascites.
And
Yes.
HE.
HE. So it's a decompensated liver cirrhosis with ascites with hepatic encephalopathy. Right? You diagnose the patient. Now, after 14 hours of your treatment, serum creatinine, which was how much? 1.3. It goes to 1.8 now. WBC, how much? 7,000. Now goes to 8,600.
8,000.
You do diagnostic paracentesis. That is suggestive of SBP. Now what will you do?
So we'll add
Antibiotic
the early person
Which
Antibiotics.
antibiotic?
and antibiotics.
Sorry?
Beta
We can add early person and antibiotics.
BLI combination, sir.
Blood culture report, it could be post-surgery infective peritonitis.
No,
Piperacillin
diagnosis has been
tazobactam.
made. It's a SBP, not secondary.
Yeah.
Right?
We can view the culture report and start the antibiotic according.
Till then you will wait.
No, we
No,
will
we should
start
right away
empirical
start.
treatment also.
Already
Yes.
Piperacillin tazobactam.
And de-escalate
Yes.
according
BLI
to culture.
combination.
Now suppose it is a secondary, then
Then we'll try to find out the cause for secondary infection.
So
no, it's a
still we are going to
polymyxosis,
start
right?
antibiotics. We will still start the patient on empirical antibiotics because anyway it's a decompensated liver cirrhosis.
No, my question you are not getting. I am telling you it's a SBP. That means how much organism?
More than
More
2.
than 200, 250 cells.
in spontaneous bacterial peritonitis, how much organisms
Yeah.
are there? That means
Monomicrobial.
yes, right. In secondary,
It's polymicrobial.
it's polymicrobial. So when we talk about polymicrobial, how many organisms you need to cover?
Gram negative, gram positive, and anaerobic cover.
Okay. So you need to cover gram negative, gram positive, and anaerobic cover, right? Anything else?
Antifungal.
Antifungal. Very good. You have given antibiotic. Now we are coming back to this case. It's a spontaneous bacterial peritonitis, SBP. You have given antibiotics. Any other thing that will be helpful in this patient?
Telepressing.
Why are you thinking of telepressing? Just
To
want to
prevent the
ask.
HR. To prevent the HRS.
Do you know is it HRS? How will you diagnose HRS?
Paracentesis might
Sorry?
help, sir.
Liver,
Parasitic
sir, liver.
tapping.
He's a patient of liver disease. Portal hypertension symptom is there, and no other cause for no nephrotoxic agent is being given to the patient.
Yes.
Anti-encephalopathy measures.
Absence of shock.
Anti-encephalopathy measures. Yes.
Shock should not be there.
Okay.
And rise of the serum create more than
Shock is not
50% from the
there.
baseline.
So first, see, HRS diagnosis of exclusion, right? No nephrotoxic drugs, right? Now, if you give something, do you think this creatinine will also improve?
Albumin, sir.
Yes. So in this, at this stage, rather than starting telepressin, right? I would go for what? IV albumin. How much is the dose
1 gram per
1 gram per kg.
on?
first 24 hours.
Sorry,
On first 24 hours.
on day one,
On day one.
and then on third day. Anyone? How do you treat SBP? There are few basic guidelines of treatment of SBP. Anyone
One
can
is
answer.
antibiotic, one is albumin, sir.
Antibiotic albumin, rightly said, madam. But how much of
Dose.
albumin? What is the dose of albumin?
1 gram per kg on day third.
And on day one,
1.5 gram per kg.
are you sure?
I think so.
Anything else? So now, on next day, same patient deteriorates. Patient becomes breathless. Serum creatinine is 3. Sodium is 130. Bilirubin is 3.5. INR is 1.8. Now patient is hypotensive. What will you do? Anyone?
Norepinephrine.
Sorry?
Norepinephrine.
Noradrenaline. Yes.
Epinephrine.
Anything else?
Telepressin.
Yes. Sorry.
Terlipressin. Terlipressin.
Terlipressin. Yes. What else will you do?
Cytic tapping, sir. And NIV.
See, this can be your exam question. You never know. You may have such kind of scenario in your exam. Then will you be telling me patient is breathless? Okay, I'll noradrenaline, terlipressin, albumin, or is there any other way to answer such scenario?
In case of
Airway
ascites, you have
breathing
to look
symptoms.
for abdominal compartment syndrome.
Okay.
So can we take this patient for CRRT for fluid overload?
CRRT for
Fluid overload.
I did not tell you it's a fluid overload, but if it is fluid overload, and if it
But
is,
it's showing hypoalbuminemia and the
yes,
septic
but
shock
it
and
is,
breathlessness can
but
be
I
the
did
third
not,
phase.
I did not tell you, but if it is fluid overload, you can go for CRRT, you can go for SLED, right? After starting your vasopressors, if I see the way you should answer, the patient is breathless, I would like to see, I would like to do the ABG, I would like to see the PF ratio, then I would like to apply the NIV. If patient is comfortable NIV, if patient is deteriorating, SpO2 is deteriorating, I would like to intubate the patient for creatinine and sodium and bilirubin INR. Patient is hypotensive. Meanwhile, I would like to start him on noradrenaline and terlipressin. I would like to send what other blood culture. So you should, whenever you are answering, think that you are answering in your exam, right? So I'm just trying to make you understand how the exam is being taken and how you should answer. If you practice like this, otherwise you will end up noradrenaline, albumin, bipair. No, just in a structured, formal way, you need to answer. It gives a good impression to the examiner. So you start with noradrenaline, terlipressin. You will do patient serum sodium is 130, create 3. You are thinking of what right now?
HRS overflow.
HRS, right?
Hepato-Renal syndrome.
Yes, Hepato-Renal syndrome. You will apply BiPAP. Okay. So how will you treat HRS? How will you treat
Albumin,
HRS
sir.
again? Yes. Yes, madam.
Albumin should help, sir.
Albumin, then
Terlipressin.
terlipressin. Yes. Now, suppose this
If
patient's PP improves, can I switch over to any other drug?
mm,
Sir, octreotide.
spironolactone.
Octreotide,
Sir,
yes.
spironolactone.
Spironolactone, no. Midodrine